The title of my talk today is Understanding and Treating Autism, the Concept of Neuroarcheology. I would like to start by explaining a little bit the unique features of a developing brain. Indeed, the developing brain is very, very active. For instance, what you have here is films taken by Daniela Preyer in Austria of a couple of weeks before birth, before delivery. One of the future baby is playing football, the other one is a mathematical problem, and the other one wants to get out. This means that the brain is really very active, and we have shown in macaque that neurons have 7,000 synapses in pyramidal neurons well before birth. So it's very active, a lot of synapses already present. However, the second important point is that the developing brain is not a small adult brain. All ionic currents, voltage-gated, transmitter-mediated, differ in the developing and adult brains. Brain patterns are also unique to the developing brain. And there are developmental sequences. Ionic currents mature progressively, brain patterns are modified progressively in an activity-dependent manner. So the question is, what is the role of this excessive or enhanced neural activity? Well, it has different roles in the developing and the adult brain. For instance, if you record a preterm baby, 28 or 29 weeks, and you put a flash of light here, you have a retinal wave as a response. This response is very long-lasting, quite incompatible with vision, yet it's present and it's important because if activity is blocked in animal models, the visual system doesn't develop very well. And these retinal waves, by the way, are present in all animal species investigated. Another example. By the way, if we do this in animals, for instance, rats, you can see that at P8, P9, when they are blind, the flash of light evokes a retinal wave. And progressively, this retinal wave is reduced in duration until P14, P15, where you have a brief response compatible with vision. In other words, activity is not really sensory, but is crucial for brain development, for visual system brain development. Another example. As you know, if we move our left hand, the right cortex has given the order. It's a voluntary movement. On the other hand, in preterm baby like this one, when he moves, the signal recorded in the cortex, for instance, here, doesn't precede the motor sign, it follows it very often, meaning it's a sort of reflex and not a voluntary movement. So what this means is the following. What we have suggested first with Nick Spitzer in California, we have suggested that ionic currents operate like a GPS in utero, providing the information needed for correct connections to be formed. They are really sort of biological checkpoints validating the construction of brain networks. Now, a neutron mutation will stop and deviate these sequences, leading to the persistence of immature currents or pattern in the brain. Now, it's as if the insult mutation or else leads to the fact that some neurons do not mature. They remain immature, and in fact, they are the direct cause of the disease, hence the term neuroarcheology. This has a couple of implications. It means that treating the inaugurating insult, for instance, the mutation, is not feasible and not efficient because the disease is caused really by the consequences of this early insult. It also means that in pathological conditions, there is a sort of return to an immature state of certain neurons or ensemble of neurons, and therefore selective blockers of these currents are suitable for therapeutic interventions because they will block the disturbance by doing a sort of pharmaceutical surgery without impacting the normal developing neurons. This is a concept of neuroarcheology which has been confirmed in various animal models. Now I'll give an example of the efficacy and utility of this concept. I have worked for decades on GABA during brain development, and I've shown with my colleagues in 1989, that GABA, in the adult system, it's well known that GABA inhibits. Why? Because when the receptor channel is activated, chloride flows in because there is very low concentration of chloride inside. This is adult neuron. This leads to inhibition and hyperpolarization. On the other hand, In immature neurons, in all animal species investigated, there is high chloride. The consequence is that when GABA is active, chloride flows out instead of in. And this leads to a depolarization, which often, not always, can be excitatory. And this is because the chloride importer, called NKCC1, is very much active in immature neuron and much less so in adult ones. And this allows GABA to depolarize and excite, produce rise of calcium, and exert its well-known trophic actions on synapse formation, growth, etc. Then we and many others discovered that in many brain disorders, this is partial list, seizures, autism, brain damage, spinal cord lesions, cerebrovascular, infarct, schizophrenia, glioblastoma, etc., neurons again have high chloride, or cells have again high chloride. It's as if there is a sort of general response of very different pathological conditions to an insult by having this co-transporter work a lot. It's phosphorylated and it works, it's very active, and therefore chloride is increased inside. The levels of chloride are increased. This is the case in many, many disorders, as I have described in that review. Now then, obviously, if you block this with an antagonist, for instance, bumetanide, which is a well-known specific blocker of NKCC1, you are going to reduce chloride and perhaps to attenuate insults. Basically, what I'm saying is the following. Young neurons have high chloride, adult neurons have low chloride because of different activity of NKCC1. In various conditions, notably in autism, some neurons have high chloride because of this, and if you block NKCC1, they will have low chloride, and perhaps then inhibition is reinstated, and this might attenuate the severity of autism. Experimentally, you can show this like this. If in immature neurons, GABA, as shown here, inhibits. In autistic neurons, GABA excites. This is the case of valproate in utero, Fragile X, Rett syndrome, and maternal immune activation, all of them being related to autism. Here, GABA excites, as shown here. On the other hand, if you treat with bumetanide, GABA again inhibits because of the low concentration of chloride inside. Is that the case, and can these be useful in treatments? Well, the answer is yes. As you will see here, this is child, Alan, before treatment. The lady, psychologist, deals with him. Can you come, Alan? Come, Alan. He doesn't listen, doesn't look at the eyes, and she insists. He switched on and off the lights. For the birthday, I put candles on the cake. Do you want to put the candles? Put the candle. Put the candle, she repeats twice, 3 times. This is 3 months later after treatment with bumetanide. For the birthday of babies, I make a cake and I put candles. Another candle he puts, and another candle he puts again. Bravo. I switch on the light. It's very hot. And we think. And he switches off the candle. Bravo, Alan. We took off the candles. Baby is hungry. He's hungry. He shows a spoon, and he takes a spoon. And he feeds the baby. Look at the number of times you look at their eyes. It's quite important. Then he wants also a biscuit. Now, of course, this is a single picture, but we have done 2 double-blind randomized studies in which we have treated over 130 children. Here with 74 children, 2 to 18 years old, we use the CAR scale, and these are three administration of bumetanide, 0.5 milligram, 1 milligram, 2 milligrams. As you can see here, there is a significant amelioration, and amelioration means a reduction or an increase of the CAS level reduction. As you can see here, for instance, every child is one of these blue columns, and you can see that the significant effect are exclusively in treated children, only one placebo. Here are the numbers in comparison with the placebo. You can see the major differences at all cases. For instance, here, 5% versus these percent alteration of CARS. We also use the SRS scale, social responsive scale, made by the parent, again on the same trial. And you can see again that the alteration, the reduction of SRS scale is much more significant in treated 12, 13, 21, 2 milligram, and only 155 in placebo. This is highly significant, according to the authorities. Now, our results have been confirmed in 3 independent trials, suggesting, after 5 trials, that we are on the way to something interesting. However, he also did something else, which is to compare visual communication with emotive figures. Here, for instance, you can see this. The adolescents are asked to look at the eyes of these ladies, smiling, furious, etc., versus neutral pictures. And there is an amelioration by bumetanide, both of the recognition of the faces and of the eye-to-eye communication. With functional MRI, this is the same. As you can see here, visual systems are activated by those pictures after, not before treatment. Therefore, we have what we have done is we are doing now a final pediatric phase 3 trial with Servier. We have joined forces, and in this final phase 3, we are recruiting, we have almost finished recruitment, 400 children and adolescents, 40 centers in Europe, USA, Brazil, Australia. We hope to have a drug by early 25. We have granted an exclusive license to Servier for Europe, but we still have the rights in the USA, Japan, Canada, China, etc. And we are looking for pharma distributor partners, particularly in the US, where for the moment we have failed. And of course, it would be quite unacceptable to have a drug, a treatment working in Europe and not in the US. One more point, we have fabricated and patenting a liquid formulation which is far more suitable for children than pills because they like it more and because liquid you can easily modify the dose by taking less liquid. Now, if that's the case in experimental conditions, because of course in human, you don't know if chloride is elevated and it has been induced by bumetanide. The only way of doing this is, of course, in animal models. Now, we discovered a couple of years ago something we did not expect, which is the following. When we measure chloride in neurons in utero and after birth, we compared chloride reduction, and we expected to have a curve like this. You have high chloride initially and low chloride subsequently. We discovered that during delivery, really during delivery, there is an abrupt reduction of chloride, very restricted in timing, and this then takes off this. In other words, during delivery, chloride is very low and GABA inhibits very strongly. This means that during inhibition, the brain will be less active and therefore more resistant to anoxic insult like shown here. Interestingly, oxytocin, the hormone that triggers labor, if you block oxytocin, you also block its reduction, meaning that oxytocin triggers delivery, triggers birth and uterus contraction, but at the same time produces a sort of neuroprotective action on the neurons of the brain to overcome the stress associated with delivery. Then we discovered that in autism model, this abrupt shift does not take place, as if oxytocin had not acted. So chloride remains elevated during delivery and subsequently. And if you give bumetanide to reduce chloride during that period, you give it to the mother, you reinstate the chloride reduction, and you attenuate the severity of autism, suggesting that birth is a critical period in the pathogenesis of autism. Interestingly, if you measure volumes of the hippocampus, the striatum, the cortex of the ventricle, in control conditions, E21, P0 control, there is no difference a couple of hours before birth and a couple of hours after birth. On the other hand, if you measure autism model, for instance, valproic acid, if you measure E21 and P0, there is a big difference, a significant increase in the volume of the hippocampus, the cortex, and the brain. If you give bumetanide to the mother, this increase in volume is abolished. So in other words, during delivery, the brain grows in autism, not in control. And this is perhaps even better shown here. These are pyramidal neurons of the hippocampus patched before in A, after birth in controlled conditions, and there is no difference between their size, their energetic carboization. On the other hand, in autism, if you compare a couple of hours before and a couple of hours after, as in D, there is a significant increase in the dendritic arbor. In other words, neurons grow during parturition and birth in autism, not in controls. Now, this has important implication with regard to the fact that, in other words, autism is born in utero, but it also impacts birth and the condition of birth and the growth pattern of the brain during in utero and during birth, where in control there is no modification in size, whereas in autism, the brain and neurons grows in addition. Of course, this has pathological implication. It means that at that stage, the brain will be much more vulnerable to insult. In conclusion, what I'm suggesting is that neuroarcheology concept provide a novel way of understanding and treating developmental disorders, notably autism. And I think that bumetanide is a promising treatment. I would like to remind you that there is, to the best of my knowledge, no approved treatment of children with autism anywhere in Europe or in the US or elsewhere. We show that children are more present. The word present is the word that the parents say systematically after treatment. They have more eye contact, they are more present, they have more social interaction. And in fact, even very severe cases, and not only Asperger or others, are attenuated by the treatment. But again, this is a treatment, not a cure. Because, of course, the misplaced neuron or misconnected are not going to migrate and to reconnect. But this is sort of surgery of the perturbation of the neurons that are perturbing. I think it's crucial, if we want to understand and treat autism, to study the work in utero and during birth. This is the key to develop a new treatment based on the alteration that are produced by the initial insult during in utero life and subsequently. And of course, it's crucial to have, as early as possible, a diagnostic in order to intervene first with behavioral treatment in order to attenuate as much as possible the severity, and perhaps later on with drugs like bumetanide or other drugs that selectively block the immature currents. Therefore, to conclude, I think really if you want to understand and treat autism and other disorders, we must work on in utero and birth. The work was done by this startup, which I have created a couple of years ago, Neurochlore, which is based really on reducing chloride in relation with brain disorders, and this institute, which I hope to construct soon, which is going to be dedicated to maternity and in relation to pathological conditions.
Thank you so much for your pioneering work, Dr. Ben-Ari. We have several questions that I'm excited to get to. I just want to make sure that I have you still on the screen. Dr. Ben-Ari, would you like to keep your camera on when you answer these questions?
I'm fine, but
Hi there.
you can hear me, but you cannot see.
I can hear you and we can see you now. It's perfect.
Okay.
Okay, so one of the questions, the primary outcomes of the bumetanide study recently done in the Netherlands was negative. Can you please comment on the phenotype biomarkers and subtypes where you expect bumetanide to be the most helpful?
Yes, the study in Holland suffers from severe limitations. In fact, they do not conclude that it doesn't work. The study has failed because they have no positive results at all. It's a sort of failure of a trial. And I think the reason is because the placebo level are very high. The kids were EEG recorded, many other treatments. And of course, if the placebo is very high, then it's very unlikely that any drug will work. I think the the main problem we have with this paper and with this contradiction with this group is that they think that no drug can treat autistic children completely. You have to restrict yourself only to a subpopulation of autistic children. They selected children who have an IQ of more than 70, who are speaking language, etc., etc. And I think that our aims are to treat autistic children, whether they are severe or not. And as therefore, I challenge the idea that autism, unlike any other brain disorders, is unable to be treated globally and not only on its subpopulation. And this sort of contradiction I also have with the genetic approach of autism, which I think in that respect is a failure in the sense that what really we want is to understand the consequence of the insult, hence the concept of neuroarcheology. Identifying more genes is interesting in terms of diagnostic, not in terms of treatment. Basically, the consequences of the insult are what we are interested in. And I still think, and our study showed it, by the way, there are new papers confirming our results, that you can develop treatment which can treat very severely impacted autistic children, and not only the ones with language and IQ and whatever. In that respect, I disagree with them.
Great, thank you. This is a question about, it says, Dr. Benarie, thank you both for your wonderful work you're doing with ASD children and for your very insightful session. Is there something special about inhibiting NKCC1 activity specifically, or would increasing the activity of KCC2 have the same result, given that it would also reduce intracellular levels?
Yeah, it's an excellent question. The issue is that when I started working on this, I had the choice between working on KCC2, basically to the listeners, KCC2 exports chloride, so in theory does the same as NKCC1 being blocked, of course. Now, the problem with KCC2, and it turned out that how should I put it? I had an intuition many years ago that working on KCC2 is a mistake. It turned out that I was right because there is not a single disorder being treated now with KCC2 activator. And the reason I think is that when you have a pathology, everybody agrees. KCC2 is downregulated, but it's also internalized. So you need a drug which brings back KCC2 on the membrane and then activates it. So you need a drug which activates the kinase, bring it to the membrane, and then activate KCC2. And this, clinically speaking, is not simple. And in fact, the most advanced study on KCC2 activation were on pain, because chronic pain has been shown in animals to be involve KCC2 downregulation, but there is no clinical trial. They have failed. I think this is the explanation. Whereas NKCC1 on the membrane doesn't move, all you have to do is block it. So it's easier.
So we have two questions I'll put together regarding mode of delivery. C-section is considered a risk factor for ASD. Do you think that your findings better explain what is usually thought as the reason to be disruption in the maternal and fetal microbiome? And also, do epidurals cause the drop in oxytocin during labor? Can this impact chloride levels?
To the second question, my answer is simply, I have no idea. I don't think so, and I have no idea. I see no reason why this should be so catastrophic. But I agree, it's a problem that, you see, can only be investigated in animal models, and I see no way of doing this in pregnant rats or mice. I think it's going to be complicated. So I have no answer to this. To the first one, I think the question is very important. It's debate. I'm not an obstetrician, so I cannot, because we have had vivid criticism from obstetricians saying that we publish papers showing that C-section is a problem. The issue is that C-section has one advantage in the sense that, yes, you have less oxytocin, but you have also less pain and you have less stress. Birth is a very, very, very stressful moment for the baby, very stressful. The levels of stress molecules, I'm talking about the baby, not about the mother for the moment. I'm not saying that the mother doesn't suffer. I'm saying that the baby has very high levels of stress molecules. This has been shown by the Swedes very convincingly. And this stress is the core of what I think is a problem, because stress is very important for the lungs to breathe, but neurons don't like that. See, if I'm right, somehow nature had to discover a trick of allowing stress to take place for the lungs, but protecting the neurons from the insult that might come because of the excessive stress. So in that respect, I think that oxytocin might play an important role. Now, whether delivery, C-section is a problem, the statistics tell us that there is a link between C-sections and autism incidence. But it's very complicated because it depends on how long before maternity, where births were supposed to take place, whether there was other complications or not, which of course modify the issue. So the epidemiology suggests there is a link, but the mechanism have not been investigated in animal models. We have published a paper in which we did C-section in mice or rats. I forgot, no, I think it was rat. The problem is that you cannot do this more than 1 day before term, because before this, the lungs are not mature and the animal die. Now, 1 day before term in the rodents, there was no effect on chloride. But perhaps this is because it was not sufficiently preterm C-section. So I don't have the answer. But my guess is that it does impact somehow.
Thank you. This is another great question for with bumetanide. How do parents handle the increased urine output that impacts toileting in children with moderate to severe autism?
You mean the diuretic effect? The diuretic effect is a classical response to. Now, our phase 3, which is done approved, the liquid we have fabricated is approved by the EMA and the FDA. Now, the liquid we're using is dosed as a much lower dose than usual. We're using now 0.5 milligram twice a day. With this, there is very little diuresis. Now, I must insist, however, that in our phase 2B, which was pivotal, which allowed us to have an agreement with European authorities to make a phase 3, we compared 0.5, 1, and 2 milligram, as I showed in the pictures. We had diuresis problems. We had some hypokalemia, which we had to treat with potassium gluconate, but we did not have severe hypokalemia. So in other words, we would never reach the 2.4 or 2.5 millimole a liter, which are problematic. And the answer to this, as has been shown also by Peter in one of your talks here, is eating bananas and taking potassium gluconate. So that's not an issue. What is important, on the other hand, is that the kidney do not suffer at all from long-term treatments. There is no effect on the kidney, which was something because treating diuresis with gluconate potassium, we know how to deal with that. We are afraid there would be long-term effects, because we're talking about long-term effects. The trial is 1 year on the kidney where there isn't. So that in that respect, we are safe.
Can you, so there was a question, and we have time, I think, just for one brief one about the dosage for bumetanide. There's a woman who's using 1 milligram in her daughter who is 8 years of age with great success. So could you give some guidance on some of the dosages that are used?
From the information I have from a lot of people using it, how shall I say, without having the permission and so forth, the doses are very variable, very, very variable. And some people give 0.5 and then switch to 1 if this is well tolerated, and perhaps even to 2. I think that 8 years old, 2 is a little bit too much, my impression would be. That's why we give it twice a day, in the morning and the end of the afternoon. The idea being in the morning before going to school, if she has a diuresis and she does what she has to do and then she goes to school, and the evening before going to sleep, which makes sense. This is why we implanted this, we discovered and implanted, and people are usually following it. And we have cases of kids which are incredibly improved. I mean, I could show films of kids going to school. It's completely unpredicted by the teachers or by the other. So there are kids in which really spectacular. Not all the kids. And the dose, of course, will vary. It depends on your weight, on whether you are fat or slim or whatever. This comes to metabolic issues that I do not master. I think it's a sort of give and take situation, trial and error.
Okay, great. Oh, and finally, which countries will the phase 3 trials take place in?
The phase 3 is taking place in Europe, 27 countries, in the US, where the COVID, of course, slowed down a little bit the issue, in Brazil and in Australia. The recruitment it's divided in 2 groups, 2 to 6 and 7 to 18 years old. The 7-18 recruitment is finished, and the result will be in a couple of months. The 2-6 is slightly more complicated because it's not very simple to deal with those ones, particularly in COVID times. So this recruitment is not finished, but we hope to finish it very soon. So the conclusion will be on the entire pediatric population from 2 to 18, but divided into subgroups. And one last point I want to insist. It's quite seldom that you have such a convergence of basic science and clinical experiments, because the trials other people did in China with Holland, China with England, and very soon another country, are literally relying on the same issues we propose, the same condition, the same dose, etc. So I think that the conversion makes me a little bit optimistic.